Today, our continuation of same activity of radiology subspecialized group, which is more marked in the musculoskeletal group, led by Dr. Amol and Dr. Avinash. And today we are starting a series of musculoskeletal ultrasound series start today by elbow joint. It will be introduced by Dr. Amol and with us also Dr. Aaron, consultant musculoskeletal radiology. I will keep some few minutes for Dr. Muhammad to introduce and starting this activity. After that, we'll receive Dr. Amol presentation and talk and receive the comment and participation of Dr. Aaron. Yes, Dr. Muhammad, please.
Yeah, so I would like first to thanks the presenter, Dr. Amol, and Professor Harun, giving this like a webinar, which is about the how we do it, normal ultrasound anatomy of the elbow. And I would, wish that this will be a successful and enriching presentation. So we can start, and thanks for our attendees, that the one that just participated and joined this webinar. So Dr. Amol, I leave the forum for you and our guest, Professor Hora.
Thank you, Dr. Mohammed. Good afternoon, all. At the outset, I would like to thank Dr. Harun for joining from UK for this short notice online CME on normal ultrasound anatomy of elbow joint. And I would like to thank Dr. Mohammed, Dr. Yasir to become panelist for this online CME. I will be discussing about elbow joint and what are the normal anatomic evaluation will be done for the ultrasound of elbow joint. This talk is properly curated based on the competency requirement suggested by the scope of practice of DOH. So it has to be given importance by all the radiologists who are practicing in Abu Dhabi and Alin Emirates. Particularly when it comes to ultrasound of MSK ultrasound, there are three components which we should be giving importance. Firstly is the anatomy of any MSK joint, which you should be knowing. You should be knowing the techniques how to do that MSK ultrasound. Once you are confident enough about the anatomy of the joint, then you should be knowing the pathologies related to that. And once pathologies are known to you people, then you should be knowing what all the interventions we should do for those pathologies in different joints. So in elbow joint, before I start, there are few dictums in the MSK ultrasound. For this talk, I don't have any commercial and financial disclosures. All the images are acquired by myself, and few images I have taken from the internet. The guidelines used for the acquisition of the images are ESSR guidelines, and this is totally educational talk. When we start the MSK ultrasound, there is one dictum that we should always see the radiograph. And when it comes to ultrasound of elbow joint, why we should see the elbow X-ray or radiograph is just to assess that elbow before starting your ultrasound. How it will be helping us out to assess before starting the ultrasound? When we see the normal anatomy of the elbow X-ray, we should be knowing the anterior fat pad. When there is an elevation of anterior fat pad, we will be more confident about there is a joint effusion. If there is an appearance of the posterior fat pad, we will be knowing that definitely there is a joint effusion or injury to the bony injury to the elbow joint. We will be assessing the additional enthosophytes along the medial and lateral epicondyle. We can be more confident about any subtle fracture or subtle radiopaque ossific focus along the elbow joint. And elbow joint is one of the joint which is commonly known for the myositis ossificans in long-term post-traumatic injuries. So you will be more confident and you will be more confident for your ultrasound, and you will rule out your surprises while doing the ultrasound if you see the radiograph before starting any elbow ultrasound. Once you are confident about the anatomy of the any joint, and you are assessing the any abnormality in that joint, always there is one dictum is compare with the asymptomatic side, so that you will get more confident about the assessment of that pathology, whatever you are evaluating. There are few checklists when we see any joint on ultrasound. There are few checklists which we should be knowing. Always we use high frequency probes. Those probes are like 10 to 17 megahertz. With us, we have Philips probes. Commonly, we are using is EL18, and Philips is having nowadays ML26 as well, which is high frequency hockey stick probe. Rarely, we are using convex probes for the deeper structures, which is like 5 to 9 megahertz. And if you keep your presets ready on your machines, like particularly we have abdominal presets, in the same setup, you should be having your musculoskeletal presets ready so that your efficiency for doing the MSK ultrasounds will be more. Those presets, like if you want to assess the general MSK or superficial part or deep part, based on that, you can just get the your application specialist help and make your presets ready on your machine. That will be more helpful for your day-to-day practice. Always keep a few things in your mind when you are doing any joint ultrasound. The adjustment of depth. Usually for the MSK ultrasounds, we prefer decreasing the depth. In few cases, we increase the depth. Focal zone is the main feature which we have to adjust whenever we are doing our musculoskeletal ultrasound, just to notify the subtle abnormalities along the tendon, along the ligaments, so that we'll be more confident for the assessment of those pathologies. Dynamic range of ultrasound machine, it is a inversely related to the contrast resolution. When we increase the dynamic range, the contrast resolution will decrease. And when we decrease the dynamic range, contrast resolution will increase. So you should be knowing this part in your machine just to adjust the contrast of whatever image acquisition you are doing. Then PRF, as we all know, we keep low PRF for the subtle vascularity assessment in any abnormalities. And rarely we use zoom, and routinely we use power and gain, and few times we use the harmonic imaging for assessment of tendons. There are few tools which are like advanced tools in MSK ultrasound. Few MSK radiologists dedicatedly working for the joint assessments. They are doing for the assessment of nerve, they are doing the panoramic imaging. A few people are doing 3D imaging. Tendons also can be assessed on elastography, which is like an advanced MSK ultrasound tool. Another important part which we all should know in musculoskeletal ultrasound is concept of anisotropy. When we are keeping our probe, this is particularly related to the tendons, nerves, and ligaments. These are very, sometimes it is obliquely oriented in our body. And ultrasound waves, when they are going in some angulation with these structures, they are giving the anisotropy. Here we can see with the angulated probe, if you see the supraspinatus tendon, there is a ill-defined hypoechoic area at the level of insertion of supraspinatus tendon. However, when we toggle this probe with the heel toe maneuver, you can see that hypoechoic area is getting vanished, which is nothing but anisotropy effect. And this can be misinterpreted as a tear in our routine practice. So you should be knowing that there is a concept of anisotropy when we are doing our routine MSK ultrasound, so that to avoid the misinterpretations. This is another example for the patellar tendon. Here you can see the angulated probe, and the echogenicity of the patellar tendon in transverse plane is ill-defined and little bit hypoechoic. However, once you keep the, you make the toggle the probe and make the head to maneuver, you can see the nicely seen patellar tendon in transverse plane. So this is one of the important concept which we all should know for the assessment of tendons. Nerves very rarely give the anisotropy because of their anatomical structure. So we can use this anisotropy to differentiate between the tendon and nerves as well. All right. So when we are talking about the ultrasound of elbow for normal assessment, we assess the ultrasound of elbow in 4 planes, mainly 4 planes. Those are anterior, medial. Along with medial, we assess along the posterior medial aspect, lateral, and posterior. So we will see these planes one by one. So anterior elbow. For assessment of anterior elbow, this is the position which we give for the ultrasonographic assessment. Sometimes we give the certain support with the pillow along the posterior aspect of elbow, or sometimes we are doing the ultrasound without the support from the posterior aspect of elbow. So when we start the ultrasound, we start from the distal part of the arm and we extend our probe in transverse plane up to the level of elbow. So we'll be seeing what all images we are acquiring in the coming slides. So what we see in the anterior aspect of elbow, this is the anatomical diagrammatic representation, to in which on medial aspect we see the median nerve, the brachial artery. On lateral aspect we see radial nerve, its divisions. Then we see the brachialis muscle, we see distal aspect of biceps. On medial aspect we see the origin of the common flexor tendons. On lateral aspect we see the origin of the common extensor tendons. On anterior aspect, when we are talking about, we'll be seeing the ultrasonographic pictures with these demarcated structures within it. When we are talking about any MSK ultrasound, firstly what we locate is we locate the bony landmark. So in our anterior elbow, the bony landmark will be distal humerus, proximal radius, and ulna. And in anterior elbow, what all things we'll be assessing? In muscles, we'll see the brachialis, biceps, distal biceps, brachioradialis, pronator teres. And in tendons, we'll see the distal biceps tendon. The continuation of fibrous structure along the distal biceps tendons is nothing but laceratus fibrosus and brachialis tendon. Then brachial artery, median nerve, radial nerve, and branches. We'll see the radial fossa, coronoid fossa, and annular recess along the anterior elbow joint. We'll see these structures one by one. So once we locate our probe from the distal aspect of the arm, extending up to the level of elbow in transverse plane. These are the planes, probe positions which we have to keep while assessing the anterior elbow. This is the transverse plane for the probe, and this is the longitudinal plane for the probe. So once we keep the transverse plane of the probe, we acquire this image. So this image will be seen when we keep our probe along the anterior aspect of the elbow, and these are the various structures. This is the lateral aspect of the distal end of humerus, which is nothing but capitulum. This is the medial aspect of the distal end of the humerus, which is trochlea. And you can see the nicely looking hypoechoic structure adjacent to this bony outline, which is nothing but your hyaline cartilage. Just above it, we'll just take the marker. Just above it, you can see one muscle, which is nothing but your brachialis muscle. And above this brachialis muscle, there will be small isotomylia hyperechoic tendon-like structure, which is nothing but your distal biceps tendon. It is giving a picture like a cherry on bun-like appearance, which is nothing but brachialis will be your distal main muscle component, and distal biceps tendon will be your cherry-like component. Once we acquire this image, you will be more confident about the other structures. Then along the medial aspect, if we see, then we will be seeing one more muscle structure along the medial aspect, which is nothing but your pronator teres. This is your pronator teres. On lateral aspect, you will see one more muscle structure, which is nothing but your brachioradialis. Once you define these muscles and the central part of the brachialis and distal biceps tendon, then we will assess the other structures. Other structures are the structures between the pronator teres and brachialis will be your median nerve here, and your brachial artery will be here adjacent to it. And on the lateral aspect between the brachioradialis and brachialis, there will be radial nerve here. These are the structures, main structures we see along the anterior aspect when we keep our probe in horizontal plane. Once we change our probe plane in the longitudinal position along the lateral aspect, you acquire this image. And in this, you can see the square-shaped radial head with the adjacent hypoechoic hyaline cartilage, then capitulum with hypoechoic hyaline cartilage, and just above it, there is one potential dip along the distal end of humerus, which is nothing but your radial fossa. Radial fossa is nothing but it is extrasynovial intra-articular potential space in which your joint effusion fluid will be collecting. Once we change our probe position from the lateral aspect towards the medial aspect, you will see the trochlear outline. You will see the coronoid process of ulna. And just above the trochlear outline, there will be again one potential dip, which will be your coronoid fossa. This coronoid fossa, again, as we have seen for the radial fossa, it is the fat pad containing fossa, and it is a potential space for your joint effusion. Next important structure which we assess in the anterior elbow is our distal biceps tendon, which is getting commonly injured and in trauma as well as in degeneration. So this is the transverse plane which we have seen in our previous images. This is your brachialis muscle bulk, and this is your cherry-like distal biceps tendon in transverse plane. Once we make our probe in longitudinal plane, you will be getting this image. This is your distal biceps tendon. However, because of the normal anatomy of the forearm, the insertion part of the distal biceps tendon is a bit difficult. So how we should be assessing this insertion part of the distal biceps tendon? We have different maneuvers. This is one of the advantage of ultrasound over MRI, in which we can do the maneuvers, and with the dynamic assessment, we can assess the exact outline of the distal biceps tendon. So which are those maneuvers? The first maneuver is this hypersupination technique. You can see with your other hand, you can just hypersupinate the forearm of the patient, keep your probe in longitudinal plane, and you can see nicely looking fibrillary pattern of the distal biceps tendon. And this is the insertion on the radial tubercle. Distal biceps tendon insertion on radial tubercle, it's a wide insertion. It is around 2.5 to 3 centimeters square, and it inserts in two components. Distal component will be the short head of the biceps, and the anterior component will be short head, and the posterior component will be long head of the biceps. Second technique which we use is going from the medial aspect and hypersupinating the forearm and seeing the distal biceps tendon through the brachial artery. It will give you the plane to assess the fibrillary pattern of the distal biceps tendon. And there is one more technique which is known as cobra position, in which we can just see the insertional component of the distal biceps tendon on radial tuberosity. So here the patient position is like this, which is like a cobra-like appearance, and you can keep your probe in horizontal plane in the proximal part of forearm, and you will see the radial tuberosity outline. This is your radial tuberosity outline, and this is beak-like appearance of distal biceps tendon insertion on the radial tuberosity. This can be assessed dynamically as well in pronation and supination position. Another important structure along the distal biceps tendon in anterior elbow is nothing but your lacertus fibrosus. You can see this is the diagrammatic representation. This is anatomic structure, distal biceps tendon, and along with that, there is a fibrous extension along the distal biceps tendon, which is going along the deep fascia of the forearm. which is nothing but your laceratus fibrosus. On ultrasound, this is your distal biceps tendon. And if you see the fibrous structure which is going along the deep fascia of the proximal part of forearm, which is nothing but your laceratus fibrosus. Another important structure in anterior elbow, which you all should be knowing, because usually we get referrals for the proximal lateral forearm pain. So in this case, we should be assessing posterior interosseous nerve, which is nothing but pin syndrome, which we call it as. So once we see, we all know radial nerve coming at the level of elbow, which is getting divided into two parts. The posterior interosseous nerve will be the deeper part, and the superficial nerve will be the another part. So when this radial nerve getting divided in two parts, the deeper part is nothing but in short axis we will be seeing posterior interosseous nerve, in short nerve axis, nice honeycomb-like pattern. And once we make our probe in longitudinal plane, it will be seen like this. So I will just show you here. So once this posterior interosseous nerve is getting formed from the radial nerve in two parts, superficial cutaneous part and deep posterior interosseous part. So this is the posterior interosseous nerve which is entering into the supinator two heads. This is the superior part, superficial part of the supinator. This is the deep part of the supinator. At the level of the entry of the posterior interosseous nerve in the supinator two parts, there is one fibrous thickening, which is nothing but arcade of Frosch. This is the potential location where this posterior interosseous nerve is getting entrapped. We have to assess this entrapment on dynamic evaluation of ultrasound at this level. If we do the pronation supination, we can evaluate the entrapment of the posterior interosseous nerve at this level, which is nothing but arcade of Frosch. Next plane for the elbow assessment after anterior is your medial elbow. For medial elbow, we keep our elbow joint in this position, and there are two. We have to locate the medial epicondyle first. If we locate the medial epicondyle, we have to keep our cranial end of probe on the medial epicondyle, and then the caudal end of the probe, we change the planes according to our requirement for the evaluation of medial elbow structures. What we see in the medial elbow is nothing but your anterior band of ulnar collateral ligament and your common flexor tendon origin. The checklist for the medial elbow is ligament is your ulnar collateral ligament, which is anterior band, anterior bundle, which can evaluate. We will be evaluating on dynamic as evaluation as well. The tendon which we will be seeing is common flexor tendon origin. And along with the medial elbow, we will be going little bit posteriorly along the posterior medial aspect. The bony landmark will be medial epicondyle and olecranon process. For medial elbow, our bony landmark will be medial epicondyle. In posterior medial aspect, we will see the Osborn ligament, which is nothing but also called as cubital retinaculum. We will see the posterior bundle of medial collateral ligament or ulnar collateral ligament, which is lying in the cubital tunnel. We will see the location of ulnar nerve. We will see how to assess the ulnar nerve instability along the posterior medial aspect of elbow. And the medial head of triceps will be lying along, sometimes it will be lying along the cubital tunnel in the posterior medial aspect. And just distal to it, we will see the flexor carpi ulnaris two heads. This is the position, probe position. We have located the medial epicondyle, and now we have kept our probe alignment towards the thenar aspect. We have to locate the medial epicondyle, keep your probe along the thenar aspect orientation, and you will see the nicely looking common flexor origin from the medial epicondyle. Once we change this position from the medial epicondyle from thenar orientation to hypothenar orientation, we can see nice fibrillary pattern of our ulnar collateral ligament. This is the ulnar collateral ligament anterior bundle, which is going and inserting on the subline tubercle of ulna. It can be assessed on dynamic evaluation. You can see we have to just pull the arm and forearm in opposite direction just to assess the integrity of the ulnar collateral ligament on dynamic assessment. Along the posterior medial aspect, as we have seen, we see the planes in three positions, just proximal to the medial epicondyle, at the level of medial epicondyle and olecranon process, and at the level of two heads of flexor carpi ulnaris. So once we acquire our image, this is the bony outline of medial epicondyle, this is the bony outline of olecranon process, and this hypoechoic structure, what you see is nothing but your Osborn ligament. This honeycomb-like structure, if you see, which is nothing but your ulnar nerve. There will be a small branch of ulnar artery along with the cubital tunnel in the posterior aspect of the ulnar nerve. And this hypoechoic structure along the floor of the cubital tunnel, which you see, is nothing but your posterior band of ulnar collateral ligament. Once we come distally to this cubital tunnel, we have two heads of flexor carpi ulnaris. These are the two heads of flexor carpi ulnaris, and this is the nice honeycomb-like pattern of the ulnar nerve. So these are the three positions we have to assess in the posterior medial aspect of our elbow joint. Here also we can see the nice outline of the ulnar Osborn ligament, then ulnar nerve honeycomb-like appearance, the posterior band of the ulnar collateral ligament. In dynamic assessment of ulnar nerve instability, we have to just keep our probe slightly on this bony landmarks, medial epicondyle and olecranon process, and you have to keep your probe alignment like this here shown in this image. And once you keep your probe, you have to ask the patient to make flexion and extension. So in extension position, you can see the nicely seen honeycomb-like pattern lying in the cubital tunnel. And when there is a snapping happening for the ulnar nerve because of the weak Osborn ligament or hypoplastic Osborn ligament, the in flexion position, the ulnar nerve will come out of this cubital tunnel. This is nothing but your dynamic assessment of ulnar nerve instability. This is the diagrammatic representation of this image. You can see the in extension position, it is nicely located in the cubital tunnel, and in flexion, it is getting snapped out from the cubital tunnel. Next plane for the assessment of elbow joint is our lateral elbow. In lateral elbow, this is the probe position. We locate the lateral epicondyle, and with this in longitudinal plane, we keep our probe. We locate the lateral epicondyle, and we assess for the common extensor tendon origin, and we assess for the radial collateral ligament. The bony landmark for the lateral elbow is lateral epicondyle and radial head. The ligament which we see is radial collateral ligament, and the second ligament along the anterolateral aspect is annular ligament, and the tendon which we'll be assessing is the common extensor tendon origin, which is one of the important tendon which is getting involved in the tennis elbow. So this is the lateral elbow image in which we can see a diagrammatic representation. This is your lateral epicondyle. This is common extensor tendon origin. This is your radial collateral ligament, and this is the synovial outline. This triangular structure is nothing but your extension of the synovium into the radiocapitular joint, which is known as synovial fringe. Here we can see wide origin of the common extensor tendon from the lateral epicondyle, and just down below is your radial collateral ligament. Just adjacent to it is your synovial outline, and there is a synovial fringe extending into the radiocapitular joint. Along the anterior lateral aspect, second structure which we see is our annular ligament. This is the radial head. This is the nice hyaline cartilage along with it. And this is nothing but your annular ligament, which is less likely involved in the injuries. Next elbow plane which we see in routine ultrasound is posterior elbow, which is again one of the commonest referral for the ultrasound of the elbow. These are the structures. This is the probe position. This is the position which we give usually for the posterior elbow joint. Sometimes according to the comfort of the patient, you can keep patient in lying down position, in prone position, and you can assess the posterior elbow. These are the structures which we see. Usually triceps muscle is coming, long head is a long head and lateral head. They are coming and forming the central tendon of the triceps which is inserting on the olecranon process. There is one more head of the triceps, which is nothing but medial head, which is coming separately and which is inserting on the olecranon process. As we have discussed earlier, which is sometimes going into the cubital tunnel as well. Along the posterior aspect, our bony landmark will be olecranon process. What we assess in the posterior elbow is posterior olecranon fossa, the tendon of tricep, and olecranon bursa for the bursitis. So in posterior elbow, we can see the nice bony outline of the olecranon process. This is nothing but your olecranon process. And this is the fibrillary pattern of the tendon of triceps, which is the central tendon, which is coming from the lateral and long head of the triceps and inserting on the olecranon process. However, we should be assessing this triceps tendon in longitudinal as well as the transverse plane, just to not to miss the focal area of involvement of tendinopathy. Once we assess the insertion of the tendon of triceps, we go proximal or cranial aspect to the tendon of triceps. We will get the one potential space containing the fat part, which is nothing but your olecranon fossa. And this is again one of the potential space in which joint effusion will be, joint fluid will be collecting. The next structure which we see is olecranon bursa. Normally, olecranon bursa will not be seen unless it is inflamed or some fluid collection is there. As we are knowing, this is the plain bony outline of the olecranon process. And if we keep the probe on this bony outline, we will not be seeing any separated bursa from the normal structure in normal patients. However, if it is an inflamed thing, then we can assess the olecranon bursa nicely, or if there is a focal fluid collection within it. However, one important thing you have to note is for assessment of the olecranon bursa, you have to get the thick gel standoff on the olecranon process so that you can see the outline of the olecranon bursa nicely. For the assessment, you should be scanning your distal posterior aspect of humerus, and you should be scanning the proximal posterior aspect of the olecranon process so that you should not be missing the minimal inflammatory changes or minimal fluid collection along the olecranon bursa. So these are the ESSR guideline link. If you want, you can just take picture of it. These are available freely on the Google, and all my talk related to normal ultrasound of elbow joint was related based on the European Society of Skeletal Radiology guidelines. Thank you.
Thank you, Dr. Amol, for this valuable presentation, and we'll keep the time for Professor Harun for his comment and the guidance.
Thank you very much for the wonderful presentation, Amol. I think elbow is a very important area where ultrasound can play a great role, because as you demonstrated, a lot of these structures are very easily accessible This allows dynamic examination as well. If you allow me, can I share one image? I would just mention, I think, one thing about the Doppler examination in the elbow area. So, Doppler examination also plays a great role when we are evaluating the lateral epicondyle, medial epicondyle, and checking for neovascularity. And that is one area where on the MR, we may see changes in the tendon, but on the ultrasound, it allows us to check if there is any increased neovascularity. And that helps us in the treatment planning. So that is one area which is also very, very useful, Dr. Amol. Obviously you are covering the anatomy topic, not the pathology. So I think the most important thing first is to know the anatomy well, and then move on to the pathology.
Yes, Professor Harun. I absolutely agree with you. If you want to share one image, you can share, Professor Harun.
I will, one second, if I can share my, one second. I will just very quickly share the, are you able to see my screen?
Yes, we can see your screen.
This is the lateral epicondyle. Typically on the lateral epicondyle, which is what we call as tennis elbow, which is a common problem. On the MR, it is cumbersome. There may be other changes, but on the ultrasound, you can see the anatomy very well. And then importantly, it helps us check for this is the tendinopathy where there is hypoechoic change, there is loss of fibrillar pattern, and we can see this neovascularity. Now, one important thing which I find is very important in MSK radiology specifically is that whenever we are checking for neovascularity, we can see this abnormal hypoechoic area and we can see the neovascularity within it. The important thing is the structure should be completely relaxed. So, for example, if you look at the elbow, in this position where the elbow is contracted, we cannot see the neovascularity. Same patient, when the elbow is completely relaxed, what I tell the patients is let it go completely dead. And when they do that, you can see neovascularity is very easily elicited. So this is one important area when we're checking for neovascularity. This is medial epicondylitis. Again, hypoechoic changes neovascularity. And I have various other examples, but equally, I think ultrasound, let me just, 1 second. Let me stop sharing. So I think ultrasound plays a very great role in evaluating different structures, as you showed, medial, lateral, anterior and posterior. So I think that's the only thing I would like to add. But overall, thank you for the great presentation. Thank you, Dr. Mohammed, Dr. Yasir, and of course, Dr. Amol.
Thank you, Professor Harun. Now we will give the space for our colleague for any question to Professor Harun or Dr. Amol.
I think Amol, you want to add something?
Professor Harun, I just wanted to know what is your experience about the median nerve getting entrapped in pronator tunnel? Is there any cases you have seen in your practice?
Not much, to be honest. I think most of these end up with having symptoms, and then finally, if we get specific symptoms, we pick them up. Most of them, I would say, are often a diagnosis which has to be achieved and often takes a few modalities over time, but I think we need a good referral base as well, people who are clinically picking up these things and then sending it to us, because I sometimes do see patients, labeled as, people find odd diagnosis and they try and move it in that direction and things might be more straightforward. But in my experience, I think it's important to stick to multiple modality, review examination, ask for help if you're not sure. But once you label somebody something, it just becomes that.
Okay. That's great. And second thing, I just wanted to know, Professor Harun, regarding the assessment of distal brachialis tendon. Because I tried on ultrasound to assess the distal brachialis tendon, how confident we will be in assessment of brachialis tendon?
See, the brachialis tendon, even if you look on the MR, the way it's located, it often has a high signal area within it. So personally, I feel it's the area of biceps tendon which is more important. But why would we looking for brachialis? Any particular pathology you're suspecting, or any?
If there is any referral for assessment of brachialis, can we assess on ultrasound? That's my question.
I would probably
Go
not.
for MR.
Yeah, go for MR. Yes.
Okay.
You'll be working too hard, and then you may not be able to give a confident diagnosis. So I think for your practice, you can do it when you're scanning the elbow, but when it becomes a specific diagnosis area, I wouldn't do it. No. For biceps, yes, biceps definitely. We get a lot of requests for biceps, but again, for biceps, if the injury is acute, when there is hematoma, when there is fluid, it is more easy to pick up. When they present 2 to 3 weeks later, after the biceps injury, when scar tissue has formed, hematoma is organized, things become more difficult to pick up. So often we do end up doing MR in those cases.
Okay. Thank you, Professor Harun. Any other questions?
Are you doing any elbow guided interventions as well? Are you doing anything for tennis elbow or golfer's elbow or anything in your center at the moment, Dr. Amol?
Yes, Professor Harun. We are doing the ultrasound guided interventions as well.
Fantastic. Yeah.
We are working with our pain management consultants over here in BMC. Yeah.
Sure. You have a great team. Nice to see everybody on Sunday. So, I wish all of you have a nice day. So, let me know.
Any other more question or clarification we need from the committee, Dr. Amol or Dr. Harun, Professor Harun?
So I just wanted to mention, Dr. Yasir, this is our musculoskeletal ultrasound series, which we have started as scope of practice of DOH has given the specific guidelines that every MSK, every radiologist, general radiologist, if they are reporting the MSK ultrasound, they should be knowing the basic competency. So all our online CMEs, we have taken the approvals from the DOH and it is accredited by DOH. So we should be facilitating in our Burjil Holding radiologist group that maximum people should take advantage of it so that they will get the certification of attendance, which will be having accreditation from DOH and it will be added for their competencies. So this is the first lecture which is there for our MSK ultrasound series, and we'll be covering all the joints one by one every month in coming months. Yeah.
Fantastic. Yeah.
We will follow this series, and once we are going to the next session, we'll announcing to all group to attending to cover this guideline from the which scope of brackets, which is announcing in the last 6 months. We can close the session now, Dr. Amol.
Yes, Dr. Nasir. If there is no question, we can close the session.
Any question from the attendee?
I think I can only thank you, the whole team, for inviting me. It's been a great pleasure listening to the talk. And MSK ultrasound is very much integral part of the MSK practice because not only it helps you as a tool for diagnosing, but it also helps as a tool for treatment when required. So I look forward to, if there are any questions, you can always drop a line to me, no problem.
Okay, Professor Aaron. Thank you for Professor Aaron for this guidance and advice. Thank you, Dr. Amol, for this valuable presentation, and we are waiting for the next series to complete the series of covering of this joint. Extend our appreciation and thanks for Dr. Muhammad Marzouki and all of our colleagues for attendance of this session. Thank you, all of you. See you in the next session, inshallah.
Thank you, Dr. Yasir. Thank you, Dr. Mohammed.
Thank you.